Thank you. Good afternoon, everybody. I am Peggy Cooley from Tacoma Pierce County Health Department, and today I'm going to do a brief introduction to hapten-induced hypersensitivity. Next slide. So neither I have had no financial or other relationships with any commercial interests in the past 12 months. The other disclosure I want to make is, if I confuse you after this is done, please check the references. They are really good, and that's where I got my information. So I hope that helps. Next slide, please. Upon completion, participants will be able to identify the difference between haptens and antigen in hypersensitivity reactions and be aware of these when treating patients for optimum care. Also, describe some strategies to manage hypersensitivity reactions to improve treatment outcomes for the patient. Next slide. So, what is a hapten? So, after 44 years of nursing, Dr. Larry Schwartz, who is our TB consultant, I was talking to him about a patient, and he said, well, you know, there's a hapten response. And I said, what is a hapten? And so, of course, I had to look it up and I had to learn about it. But basically, it's from the Greek word haptene. I don't know if I'm pronouncing that correct, which means to fasten. And it's basically when a minute molecule attaches or conjugates with a larger protein molecule, that allows an immune response in the body. And some of the haptens, which really shocked me, nicotine and morphine are listed as haptens. Also, most drugs are haptens. Next slide, please. So, hopefully this diagram from Mr. Sushi Humagane helps. So, hapten alone cannot do anything. It cannot create an immune response. But when attached to a carrier molecule, together, they call it a conjugate sometimes, that creates, it can induce an immune response. Next slide, please. So the carriers, they can be infectious agents, they can be insoluble foreign matter. There's many different carriers. Next slide, please. So what's the difference? So an antigen is something that can work on its own. It can cause an allergic or an immunologic response all by itself. Haptens require a carrier before they can cause an allergic or immunologic response. So that's, sorry for the noise. So that's the main difference between the two of them. Next slide, please. So when we look at immune responses to antigens, these occur not with the initial response, but upon re-exposure. And there are 4 different types of hypersensitivity responses. You notice type 4 on the far right, that's from T cells, and that's where our TST gets the delayed hypersensitivity reaction. The one I'm going to talk about today is type 1, and that's anaphylaxis and hay fever. So these are drug reactions and hay fever. The other 2 reactions, drug-induced hemolysis, is you see it with ABO incompatibility. Okay, next slide, please. So for your primary sensitization, you have the drug plus the protein. You now have a hapten. It goes into the lymph tissue. It induces the T cells to proliferate with short and long-term memory for this hapten. That's the first sensitization or first exposure. When you have a secondary exposure, you've already got the T cells in place. It causes the reactivation of the T cells, and then the response occurs. Next slide, please. So what does the reaction look like? Urticaria, angioedema, which is deep tissue swelling, respiratory symptoms, shock, and severe cardiac complications. So when we think about an anaphylactic reaction, these are the reactions that we're looking at. Urticaria, hives, things like that, difficulty breathing, tightness in the throat. Of course, it can lead to shock and cardiac symptoms. Next slide, please. So the question is this Hampton response, is this what occurred to my patient? She started on 4 drugs. After 25 doses, one day my outreach worker went out and both lips were swollen about 5 times their normal size. There was no other swelling on the face, no difficulty breathing, no rash, itching, anything like that. So we held the medications. She does live 15 or 20 minutes from a hospital, so we made sure that if she noticed any difficulty breathing, to please call 911, not to get in her car and drive to the hospital. And then we continued with the daily outreach worker visits, not only to check and see if this angioedema was reducing, but also because the patient was in isolation, we needed to ensure that she was remaining in isolation. Next slide, please. So this was our plan. The doctor ordered an EpiPen, 50 milligrams of Benadryl Pre-Med, and our DOT outreach worker was to stay at the house for a minimum of 20 minutes after the medications were given. We did the drug challenge, so she did a pre-med of 50 milligrams before Benadryl, before we arrived, and then we did 3 days of INH, and then we added PZA, and we were using this order of medication challenges because we were pretty sure this was the rifampin that was causing it. So then we added EMB. On the rifampin, the first time we gave rifampin, we went through the emergency procedures again. We went through how to inject the EpiPen, and she had to go through the motions of injecting an EpiPen. She is an LPN, so she didn't have as many qualms about doing an injection, about calling 911. She took the rifampin, and we stayed there for about 30 minutes. There were no further reactions. Again, we went over about calling 911. Next slide, please. Okay, so I would love to hear your discussion about what you think about Hampton's and Hampton response, and see if this is what you've noticed in your own practice. And again, these references, this is where I got all my information, and what I could see from these references, this is a lifetime's work. This is not something that you learn about in 9 minutes. Thank you.